Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Late Infection-Related Mortality in Asplenic Survivors of Childhood Cancer, a report from the Childhood Cancer Survivor Study by Weil et al. My name is Cindy Schwartz, and I am the Rebecca Sly Professor of Oncology and the Chief of Pediatric Hematology, Oncology, and Transplantation at the Children's Hospital and the Medical College of Wisconsin. My oncologic specialty is pediatric oncology, with expertise in Hodgkin lymphoma and the care of survivors of pediatric cancer. The Children's Cancer Survivor Study is a multi-institutional study of 5-year survivors of childhood cancer diagnosed between 1970 and 1999. This particular analysis compared late outcomes of survivors of childhood cancer who had splenectomy or splenic radiation to those who had neither. The National Death Index, or state death certificates, identified deaths related to sepsis, meningitis, or pneumonia. Complete radiation and surgical data were available for more than 20,000 patients who did not receive total body irradiation. The 1,354 patients who underwent splenectomy, of whom 94% had Hodgkin's lymphoma, had a 0.67 death rate due to infections per year, in comparison to 0.16 deaths for the 9,442 patients with splenic irradiation and 0.05 deaths for those without either. The cumulative incidence of late infectious-related mortality at 35 years were 1.5%, 0.6%, and 0.2% respectively for these cohorts. This represents 7-fold and 3-fold risks attributable to splenectomy and splenic radiation. The risk increased with dose of splenic radiation. Of note, age and rate of mortality were highly correlated, with the risk rising exponentially after the age of 40 years. The impact of splenectomy on infectious risk was first identified in infants in 1952. While young children are at greatest risk, older asplenic children and adults have an increased risk of infectious death. Pneumococcal, meningococcal, influenza, and H-flu vaccinations are recommended by all sources. Daily prophylactic antibiotics, or the availability of antibiotics for rapid administration at the first sign of illness, are recommended in the U.S. for young children, but not for those over age 5. Recommendations in many other countries do include antibiotic prophylaxis for all asplenic patients. This difference is based on a presumption in the United States of a lower incidence of infectious death in older patients, evidence that vaccines mitigate these risks, and lack of evidence of benefit for oral antibiotics, except in specific cohorts such as preschool children with sickle cell disease. These conclusions were, however, determined based primarily on outcomes for the initial 5 to 10 years post-splenectomy. In the report that accompanies this podcast, the Childhood Cancer Survivor Study has now shown that the risk of infection increases decades after therapy began, associated with attained age. Reliance on the National Death Index limits reporting bias in this analysis. Recurrence and secondary malignancy do not impact these outcomes when measured either by multivariable or competing risk analyses. Although the subjects have had cancer, most are in long-term remission, and all are at least 5 years from diagnosis, with a median of 26 years of follow-up. When patients enter this cohort, the first-line cancer treatments are complete. Toxicities associated with acute therapy are therefore excluded. While conclusions can only be specific for the cohort of childhood cancer survivors, their recovery from treatment may suggest relevance to other cohorts as well. This study is limited by a lack of information regarding prophylactic measures applied to individual patients. For older patients, few recommendations may have existed regarding prevention in their treatment era, and information regarding the increasing efficacy of vaccines may not have reached them. Although it is likely that vaccine alone significantly mitigates long-term risks, many of these patients actually may have been immunized. If so, the exponential increase in infectious mortality may be attributable simply to age-related changes in immune function, further predisposing the older asplenic patient to this risk of death. The Childhood Cancer Survivor Study highlights a previously unrecognized risk in long-term survivors of childhood cancer. The escalating risk over decades suggests the need to reevaluate our stance on prophylaxis and education of those at risk. Recommending maximal prophylaxis with both vaccine and daily or readily available antibiotics may be more protective than reliance on one modality alone. Unfortunately, vigilant compliance with vaccination and prophylactic antibiotics is generally too low and wanes as the years proceed. This is attributable both to the patient and likely the medical system itself. In our current era of computer-based medical records that contain information focused on the last decade, we are in dire need of methodology to capture long-term medical history. To save lives, we need to retrieve information of early therapies that engendered risk and introduce educational programs for those affected. Current access to the healthcare system at times of febrile illness may further jeopardize patients at risk. This very late risk of infectious death after splenectomy has not been previously reported for survivors of childhood cancer and deserves additional consideration of the differences in standard of care for post-splenectomy patients in the adult versus pediatric care systems. If the age of 40 is a new risk factor for infectious death after splenectomy or splenic radiation, the adult care system will need to address this challenge. Counseling regarding risks associated with fevers and need for immediate care for fevers, possible use of oral antibiotics, and the need for compliance with vaccination schedules is required. There are 25,000 patients who undergo splenectomy annually, up to 1 million splenectomized patients in the U.S., and additional patients treated with splenic radiation. Although splenectomy has not been a standard diagnostic procedure in Hodgkin lymphoma since the late 1980s, a significant cohort of Hodgkin lymphoma survivors are now more than 40 years of age and are at enhanced risk of infection-induced mortality. Even now, some continue to get splenic radiation. Overall, patients with functional or anatomic asplenia represent a large cohort whose long-term survival might continue to be at risk and may need a carefully monitored introduction of prophylactic regimens with close attention to compliance and to formal education of the patient. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.